student intern with the Surrey North Delta Division of Family Practice.
I'm Lawrence Yang, I'm a GP from Surrey.
So we have some thanks and acknowledgements. I'd also like to acknowledge the BC Patient Safety and Quality Council for providing financial support for myself during this. And neither myself nor Dr. Young have any conflicts to disclose. We'd also like to mention the Provincial Opioid Agonist Therapy Support Program through the BC Centre of Substance Use, and they provide the provincial gold standard for opioid agonist therapy guidelines as well as Suboxone training. So OATForce or OATForce, some of you may know OAT as an acronym standing for Opioid Agonist Therapy. But what is opioid agonist therapy? I'd just like to define that a little bit for everyone. It's a therapy where family physicians or physicians provide medication to patients that's safer than street opioids, and we try to prevent them from finding street opioids or opioids anywhere else. So some relevant statistics that are interesting to know for the opioid crisis as it currently stands is that the first two statistics are from 2016, where 78.6% of the overdoses that occurred were caused by fentanyl. So the drug supply that is currently out there is contaminated. It's also an interesting statistic to note, and it might challenge some of your ideas, that 90% of those overdoses occurred indoors. So we typically think of that population as being street entrenched. That might not necessarily be the case. In 2010, we saw 211 deaths from overdose, and that raised to 1,489 in this past year, 2018. We're up to roughly 4 deaths per day, so it's a huge number. If you compare it to something like road traffic incidents, there were 278 deaths. I believe that was 2017. So it's quite a big number, and it's currently prevalent and growing. So this big number here is $3.4 billion is the cost of opioid overdose throughout Canada. And that number is from 2014, so as the opioid crisis currently stands, we can imagine that this number is probably quite a bit higher today. That includes things like criminal justice costs of $1.1 billion, and so that includes things like policing, courts, and corrections. $313 million in health-related costs includes things like emergency department visits, specialists, physician time, and prescription drugs. And then finally, lost productivity costs of $1.8 billion include things like mortality, disability, and absenteeism from opioid use.
What really enabled our project to work was that I was able to get some skills from the Clinician Quality Academy here from the council, as well as from the Physician Quality Improvement Program in Fraser Health, as well as from the IHI coaching course. We were able to bring some of those techniques that really help with engaging physicians in this type of work. It is high barrier work. So we use the techniques such as liberating structures, for example, something I wouldn't have known before QI training. So doing things like TRIZ and bringing about what are these stumbling blocks? What are the barriers that are getting in the way of family physicians trying to do some good work? We recognize that the BC Centre of Substance Use is the gold standard for training people in how to do really good Suboxone work. We felt the Suboxone work was perfect for GPs because it is exceptionally safe. It's an opioid that even if you take quite a lot of it, it does not suppress respiratory centers as much as full agonists. So, and it is a strong binder to the opioid receptor, so it can actually outcompete many opioids on the receptors.
But please imagine yourself as a family physician. So imagine yourself as a family physician. Imagine that you're worried about your patients, you're worried about the community, you're worried about the opioid crisis in general, and you want to know what it is that you can do to help this problem. So your division of family practice approaches you, and they tell you that there's an opportunity for you to learn more, and that there are education sessions that are being put on by the OATForce. So you decide to attend some of these education sessions, and while you're there, you connect with your peers, you learn about trauma-informed care for substance use disorders and opioid use disorders. You get support in doing the Provincial Opioid Agonist Therapy Support Program from the BCCSU. You will hear from people in person and virtually about lived experience, and you learn to modify your clinic workflows. So these are all things that you learn while you're there. You're also given the opportunity to join the OATForce WhatsApp group, which is a place where you can continue your learning. You You can ask questions freely of other physicians who are doing this program. You can share different experiences, and you can get feedback from your peers of all different experience levels. You're feeling a little more comfortable at this point, but you decide that you need a little bit more practical training. So your division tells you that there's an opportunity for you to be able to go into another family physician's office and do an observership that they're calling it, where you can see them doing opioid agonist therapy in their own practice. So you shadow them for a few hours, and you get to see physician and patient interaction firsthand. Finally, you're feeling comfortable, you're ready to start prescribing opioid agonist therapy, and you decide to join the list of names of family physicians who are ready to take on stable patients from the health authority. And this frees up space for patients to get the care that they need in those centers. It's really important to note that all of these steps are non-compulsory because we want to try and make sure that physicians have the lowest barrier possible in doing this. So as part of the education sessions, we've learned that one of the most impactful ways to try and break down stigma and change people's thinking is people with lived experience. One example of that was with Serena, who we were connected with through the Patient Voices Network. And she was a person who had used heroin to self-medicate for past traumas for nearly 8 years. She had experienced quite a bit of stigma from healthcare practitioners in her life, and was eventually able to find a family physician who provided her opioid agonist therapy and who supported her through her journey back off of using any opioids. She's now been off of any opioids for nearly a decade, and in the brochure that was on your seats, there is actually a link to a YouTube video where you can see hers and a few other stories of people with lived experience.
It's the trifold one. Yeah. So big thanks to GPSC, the General Practitioner Services Committee, for giving us a grant to run this program. It's an innovation grant, and with it we were able to fund sessional time for physicians to come to the table and to have some meaningful conversations. We recognized that physicians connecting with physicians, peer interactions, we really needed to build that first as a foundation going forward. We used some of the techniques that we learned from quality improvement about how to run team meetings, and made sure that the agendas were designed so that there was human connections before every one of the meetings. We had made sure that we used facilitation techniques that are tried and proven to ensure that every voice at the table was heard. We made sure that we programmed in strategically a sustainability plan and made a WhatsApp group where the physicians could connect afterwards to ensure that they could connect about clinical questions or even about wellness or clinic management issues. We ensured that all the discussions had that due process that every physician could experience as they co-created and adapted the design of this program to make it meaningful for them along the way. We started off with an air of psychological safety. We deliberately used that term at the first meeting, and now we've had 20 meetings and we don't forget to use that word. Because it's using that fluency and getting that fluency of that language out there that really, I think, starts to shift culture. One of the things that safety brought was that physicians became engaged, and one of those physicians, one of our champions, actually brought in one of their patients to the table. He wanted to be called Dave for obvious reasons, but we heard his story of how getting onto Suboxone saved thousands of dollars for him. He was spending $300 a day on fentanyl prior, but then by going on Suboxone, there's actually no cost to him actually in our province, and he's thriving again with his family. That really inspired the other GPs seeing their peer do that to try to get into this issue.
So $57,000, it's a large number, but it paid for sessional payment for doctors to go through all of these education steps and to bring them to the table through sessional payment. They also included funds to hire division staff, and with that we were able to approach 80% of the longitudinal care family physicians in the community of Surrey and North Delta, and that works out to roughly 100 physicians. Another thing that we were able to accomplish with that was to open up patient slots to get care for opioid agonist therapy. Previous to the OATForce, there were 0 identifiable slots in Surrey and North Delta for patients to receive this care, and now we have the capacity for 46 patients to get through opioid agonist therapy using buprenorphine and naloxone. So of the roughly 100 physicians that we were able to approach, 39% of them were engaged in coming to education sessions, and 14% of them decided to join the list of new prescribers for opioid agonist therapy, and they gained the capacity to do that in their clinics. So no project like this comes without its challenges, of course. And some things that we identified as potential challenges for physicians to take this on were things like time. So we all know that family physicians are very busy people, and it's hard for them to start anything like this. Stigma is definitely something that exists in the physician community, and it might affect a family physician's choice to start treating this population. Complacency just refers to a fact that a family physician might be happy with the way that things are running in their clinic, and they might not be willing to change anything at this time. The skills gap just refers to the lack of confidence that a family physician might feel in prescribing buprenorphine and naloxone. So all of these 4 things are what we aim to address at the education sessions to try and get over some of these barriers. So in the time that we've been doing this project, we've discovered that for this, and not just this, but any project to succeed, there needs to be a system of trust between all of these entities that you see here. So the health authority, physicians, the divisions of family practice, as well as the vulnerable populations that they surround.
Anybody plays the Link or Zelda? This looks like Link or Zelda. So yes, so part of sustainability is ensuring that when we're hiring at the divisions in terms of engagement staff, we know that physician engagement is an issue. Making sure that we're hiring doing values-based hiring and skills-based competency hiring, where there's a significant level of persistence and resilience in the face of rejection from the front desk staff. We need to be able to penetrate to get to the consciousness of GPs in the communities, to take care of them, really, give them a sense of safety, and then from there we can innovate together and learn. The stigma, as Meaghan mentioned, it still exists, and when we are all suffering from burnout, there's no way that we have a deficiency or an empathy fatigue that we have to learn somehow regenerate, and the regeneration comes through connection, through meaningful connection. One of the greatest challenges moving forward, and one of the missteps of our project, is we didn't do a meaningful engagement where clinicians from the GP side actually met with clinicians on the health authority side. So the trust wasn't built. So even though we're saying we're ready to take these 46 patients, the physicians, the clinicians, very kind clinicians who've built bonds with patients on the health authority side are reticent to let them go. So the flow has not happened, which was one of the aims, but we missed a step there. And again, the BCC SU is foundational for all practices, British Columbia, potentially worldwide, in terms of opioid agonist therapy.
So we'd like to just finish off with some main takeaways for anyone who might be interested in starting a project like this for themselves. So it's very important to get a GP champion who's passionate and involved and willing to foster peer relationships with other family physicians. It's also very important to make sure that protected time is offered to family physicians so that they actually feel as though they can come to the table, come to education sessions, and learn. We were lucky to have a diverse group of people in our working group, and it included people from emergency health services, coroner service, we had nurse practitioners, division staff, patients with lived experience, and family physicians, as well as others who were able to come in and broaden the experience and ensure that we had as many lenses as possible working on this.
I want to make sure that you understand that Meaghan is a student at SFU. She was partially funded by the council in order to start with us. None of this would have been possible without her. I want to give a shout out to everybody on the WhatsApp group from the OATForce. The OATForce was coined by Dr. Sujatha Nilavar, one of our rising young leaders in Surrey North Delta Division.